Great. So I'm really pleased today to introduce one of our repeat presenters, which means a great presenter and very much appreciated. Michael Chen is an associate professor of medicine, cardiology at UW Harborview Medical Center. He has special expertise in treating older patients with cardiovascular disease. He came to the UW in 1999 for an internship and residency in internal medicine, and then also completed fellowships in gerontology and geriatric medicine and cardiology. He's board certified in cardiovascular disease, and he's going to talk with us today about hypertension in older adults, a case-based discussion. Welcome, Dr. Chen.
Thank you so much. It's a pleasure to be here virtually. It's not so much a pleasure to be in my office. I'm here a lot. At Harborview, also in Seattle, and I can confirm that it's a bit sunny. I really appreciate all of the attendees for being here, and in return, I will not mention COVID once for the entire hour or hour and 15 minutes, however long we go. I hope, though, that all of you have been doing okay, both professionally and personally, health-wise, with regard to the pandemic. My background, I should mention, is a piece of art that hangs in my dining room, actually. It was produced by my niece, who is an artist. She's also in social work school planning to do art therapy. I usually get some questions about that. I will refrain from giving you her website because I'd have to include another disclosure slide if I were to do that. But it's also, talking about the art is also an opportunity to emphasize that we often say that medicine is part science and part art. And when we're talking about the management of hypertension in older adults, particularly very old, and or frail older adults, there is a lot of art and much less science, as we'll discover. Please do ask questions in the chat, even as we're going along, particularly if there are any abbreviations or jargony language that I'm using, and Barbara can clue me into that. Otherwise, I guess we tend to save questions to the end, but any pressing questions, I'm happy to try to answer. And again, because a lot of this management will turn out to be art, there may not be a sort of a one correct answer. So in terms of an outline, we'll talk about the scope of the problem, how we might determine an appropriate management strategy, particularly for special populations of older adults. We will mention some special consideration for various medications and their use in older adults, and then a few particular challenges that we might face or that you might face in the management of hypertension in older adults, particularly orthostatic hypotension, resistant hypertension, and a few other problems. So as you know, because of great medical care and folks taking care of themselves, the population of older adults is growing pretty rapidly. And by 2050, 7.4% of people are estimated to be over 80 in the US. And that's twice the percent from just 2010. Hypertension affects almost half of the US population. The incidence of hypertension at any given age has been relatively stable. But again, the overall population continues to grow. And around 70% of those over 65 have hypertension. And the lifetime risk of developing hypertension for someone who's in their 50s to 60s, mid-50s to mid-60s is over 90%. And age is a potent risk factor for all forms of cardiovascular disease except for congenital heart disease. Hypertension, this is seen here in this graphic. And as one of the, in the invitation to give this talk, it was recommended to talk about health disparities when appropriate. And this is just a breakdown of the prevalence of hypertension over time, separated by into various ethnic groups. So NH means non-Hispanic, white males, white females, Black males, Black females, Mexican American males, and Mexican American females. And this is just to show that there are some fair differences with regard to the prevalence. Not so stark as, I'm going to skip ahead, as there may be in recognition, management, or treatment and control of hypertension, though. Why do we care about hypertension? It's often been called the silent killer because it is serious, but most folks in general don't feel their hypertension, particularly if it's longstanding and has developed over time, even if it's fairly severe. If it's increased gradually, folks may not have any symptoms until they have end organ damage. But as you folks know, hypertension is a potent risk factor for stroke, coronary disease, sudden cardiac death, heart failure, peripheral vascular disease, end-stage renal disease. And the relationship of between blood pressure and the risk of cardiovascular disease is continuous and independent of other risk factors. So the higher the blood pressure, the higher the risk is. And this has been shown into the 80s age range in larger epidemiologic studies, so population-based studies. And it's been estimated that each increment of 20 over 10 millimeters of mercury, that's systolic over diastolic, doubles the risk of cardiovascular disease across the entire blood pressure range, starting from a low of around 115 over 75. And the lower end of this range varies depending on age and the functional status of the population studied. And we'll talk a little bit about sort of this lower end a little bit later. In older adults, systolic blood pressure and pulse pressure, so the difference between systolic and diastolic, are more indicative of cardiovascular disease than is true in younger adults, such that high systolic with a low diastolic blood pressure carries increased risk. And it's also true that the systolic blood pressure alone is less informative for cardiovascular disease in folks who are frail, or who are multimorbid. In younger adults, diastolic blood pressure is a more potent risk factor, more directly related. And that's because hypertension in younger adults is more related to their peripheral resistance. So you can kind of think of it as how clamped down their blood vessels are. And their hypertension tends to be less variable. So what do I mean by hypertension sort of having different etiologies in younger versus older folks? So until about the 50s or 60s, both systolic and diastolic blood pressure tend to increase. But further increases in the systolic blood pressure tend to be because of arterial stiffness. So less compliance or more stiffness, kind of saying the same thing, occurs as we age. So the arteries, the larger arteries, get stiffer, and that results in a higher blood pressure or higher systolic blood pressure, and then with a fall, a more rapid fall to a lower diastolic blood pressure, and therefore there's an increase in pulse pressure. And each of these is associated with cardiovascular disease events and all-cause mortality. The reasons for this arterial stiffness include hypertrophy of the wall, calcification, garden variety atherosclerosis, and changes to the extracellular matrix around those arterioles. And then there are also functional changes in the endothelium and smooth muscle with differering responses to nitric oxide, for example. So as I mentioned, awareness, treatment, and control of hypertension is variable amongst groups. And then overall here we see that although there's an increase in recognition of high blood pressure as folks in the older and older age groups, so blue being in the younger, sort of more middle age in red, and then over 60 in yellow, in all cases, there is less treatment than there is awareness, and there is less control than there is treatment. So there's room to improve for sure. And here is some variability based on, again, specific ethnic groups from the NHANES study, showing some variability with regard to all three areas: awareness, treatment, and control. We also know that worldwide, mortality related to hypertension is higher, or rates of mortality are higher in lower income countries than in higher income countries. So these disparities occur not just within the US, but worldwide. So how do we define hypertension? As you know, there have been JNC up to JNC 8 and other consensus documents and so forth. This is the most recent 2017 ACC-AHA classification, where normal is less than 120/80. Pre-hypertension between 120, 139, and 80 and 89, stage 1 and stage 2. And we're not going to talk much about therapy here, although the therapeutic recommendations in these consensus documents tend to be fairly similar in older adults. So again, the reason why we care about hypertension is because of the downstream effects or end organ damage that can occur, and because treatment can reduce the risks of those outcomes. So stroke can be reduced 35 to 40% with hypertension control, MI 20 to 25%, heart failure up to 50% with hypertension control. And on sort of a number needed to treat basis, with stage 1 hypertension and additional risk factors, having a sustained 12 millimeter of mercury reduction over 10 years prevents 1 death for every 11 patients treated. So that's a pretty low number needed to treat. It's interesting, you know, some people care very much about their blood pressure, and there can be pride and shame when folks come to the doctor and they either bring their blood pressure record and they'll say, "Oh, I didn't do very well, doctor, you know, this is my blood pressure record," or even just a single value. You know, folks will come in, they'll have had trouble parking. We don't have wonderful parking here at Harborview. And so they may have circled the parking lot a number of times or had trouble getting here because of traffic, and they're all worked up, and you know, the MA is rushing to get them into the room, so they get their blood pressure checked and it's high. And so, you know, even before I sit down, sometimes the patient will start to be embarrassed about the level of their blood pressure. On the other hand, you'll also, I'm sure you all have seen or had patients that come in with their record very proud of what their blood pressure is. My parents are, my dad's 91, my mom's 92. And whenever they go to the doctor or have an appointment and their blood pressure is good, they're always very proud to report what their blood pressure was. You know, at this age, I often, you know, say, "That's great. Are you sure you're not lightheaded or dizzy?" And you know, they adhere to a very low salt diet and do all sorts of other things. And I try to let them know that they can perhaps be a bit more liberal with regard to their lifestyle choices, but they are very committed to controlling their blood pressure. Interestingly, and some of you are probably thinking of this already or may already have thought of this, studies have showed an inverse relationship in very older adults between blood pressure and cardiovascular disease outcomes or all-cause mortality. In other words, low blood pressure being an adverse sign. And there are some reasons why this finding might, or some possible explanations for this. It may be because the blood pressure has been lowered excessively or too quickly by being on too many meds. patients may be dehydrated. They may have lost weight and their blood pressure hadn't been monitored. On the other hand, it may be that folks who are able to stay hypertensive even in advanced age and with multiple comorbidities, that may be a marker of better health in a way without some of these other things. And it's important to know that the need for antihypertensive therapy may decline over time. So deprescribing intentionally to avoid complications can be beneficial. So here is this U-shaped curve that some of you have probably already pictured in your head. This is one such curve from the INVEST trial where the primary outcome was first occurrence of death of any cause from any cause, non-fatal MI or non-fatal stroke. And what you can see here, we have systolic and then diastolic blood pressure, that as you go down until an inflection point, there is a reduction in all of these adverse events. But then as you go lower, there's an increase. And that's particularly true in the older age groups, 70 to 80 and then over 80. And other observational studies in very old, frail patients have suggested that a systolic blood pressure less than 130 is associated with higher morbidity and mortality in folks who are on treatment, but not in those whose blood pressure is quote, naturally low. Possible explanations are because patients treated have had a longer history of hypertension, so have had more time to develop complications relative to their hypertension, or maybe because treating hypertension in this age group worsens their prognosis. The hypothesis is that lowering blood pressure too much causes end organ tissue hypoperfusion and therefore complications. So I mentioned all of these various, over time, various guidelines and consensus statements, and just not to remember the details of these, but the 2013 guidelines, now almost 10 years old, suggested that in the over 80 age group, which we're going to kind of focus on for the remainder of the talk, for the most part, folks should be treated if their systolic is over 160, targeting a blood pressure of less than 150. The North American guidelines specifically recommend not modifying your treatment based on frailty, and we'll get into that in a little bit. And then just to focus here on essentially where we are now, the 2017 ACC/HEA guidelines suggest starting therapy in all people, including those over 65, to achieve a blood pressure less than 130 over 80, utilizing clinical judgment and patient preference with factors such as low life expectancy, multiple comorbidities, and other relevant concerns, recognizing that randomized control trials in patients with frequent falls, advanced cognitive impairment, folks who are institutionalized, just haven't been done. And then they also recommend utilizing a team-based approach, and we'll talk about that a bit more. So we're going to skip the latter part. There's not a whole lot of specificity there, though they just say, take these things into account, and that's, I guess, where a little bit of the art of medicine is going to come in. You'll notice, as in other areas, that what's older differs. Some statements or guidelines have said, over 65 or over 60 or over 75 or 80. And, it makes sense that age is probably not the best way to guide targets and therapy. Rather, sort of if there was a way to say physiologically how old this person is, or functionally, and with regard to comorbidities and so forth, together with age might inform a relevant strategy. So there was a really interesting article that I'm going to focus on for the next several minutes, written in the journal Hypertension, advocating for the use of an evaluation of frailty and functional status to help guide treatment recommendations for hypertension in older adults, particularly those over 80. And frailty, as you know, is a multidimensional syndrome of a loss of reserve. So more vulnerable to setbacks, whether that's a physical orthopedic problem, like a fall and fracture, or a medical illness. They just have less reserve to be able to deal with that. A cardiovascular example is a patient with diastolic dysfunction who's not really symptomatic from it, but then they get atrial fibrillation, they lose the atrial kick, and then they develop heart failure. They just can't tolerate that additional hit. Frailty has been measured in various ways, sometimes physically with things like grip strength or walking speed, for example, as well as sort of more of a functional assessment. And we'll talk about the clinical frailty scale that probably most of you folks are familiar with. But the use of frailty rather predicts dependence, hospitalization, institutionalization, and death. But it has also been used to determine the appropriateness of certain interventions. In the cardiovascular disease realm, it's been shown to be useful in helping to manage folks with heart failure, to help select folks who are likely to do better with transcatheter aortic valve implantation, TAVI or TAVR, to help determine whether folks are likely to do well with cardiac surgery, in addition to the cardiac surgery risk calculators, atrial fibrillation with regard to management strategy, and even in diabetes. So you folks may be familiar with some of the bigger trials or more famous trials in hypertension in older adults. HIVET was a placebo-controlled randomized trial looking at mortality and cardiovascular outcomes in folks over 80, which showed a benefit for treatment and therefore undergirded was the foundation for the 2013 European Society's recommendations. And those were, if the initial systolic blood pressure was over 160, try to get it under 150. And if the systolic is less than 140 on treatment, but it's tolerated, then you can continue. SPRINT was another randomized trial in folks over 75, which showed a benefit of lowering blood pressure even further to a systolic under 120. They did post hoc analyses, which didn't find an impact from frailty. And therefore, the 2017 Canadian guidelines said, you know, don't change your treatment based on frailty, because look, we have all this, we have this randomized trial data. Unfortunately, very frail subjects were excluded from both studies. Subjects were relatively fit. Those in SPRINT couldn't have even had diabetes. They were community dwelling. They didn't have dementia or significant cognitive decline. They couldn't have multiple cardiovascular risk factor or other comorbidities. They couldn't have had orthostatic hypotension, other metabolic disorders, including diabetes. Couldn't have any loss of autonomy. And furthermore, there's been a little bit of controversy about how the blood pressures were measured in SPRINT, which suggested that perhaps the blood pressures that were recorded as less than 120 systolic were actually more in the 130s. This is not to be looked at in detail. It just lists the exclusion criteria from HIVET in the middle and from SPRINT, and you can just see all of the things that led to exclusions. And you can think of the setting in which you are practicing and working, and how many of these of the patients and people that you see on a daily basis would have been eligible to remain in the trial versus would have been excluded for one of these reasons. Essentially, all of the patients that I see would have been excluded from these trials. So these are the best data, are really strong data for the population that was studied, but don't apply necessarily quite well to the patients that we're seeing. So the potential for using frailty and functional status in folks with hypertension to try to help determine what the best strategy is to control their hypertension has some appeal. But we have to admit that there isn't a whole lot of data behind it. And that's one of the things I'll talk about towards the end or at the end of the talk, is that we do need more data to know how to treat these folks that are excluded from these bigger trials. I've already mentioned that frail folks who have blood pressures that are too low often are seen to not do well, and those folks who are dependent or are multimorbid or have multiple comorbidities were excluded from most of the randomized trials. So some have advocated for the use of comprehensive geriatric assessment to help risk stratify folks to different management strategies, whether it's in hypertension or in other disease states. True comprehensive geriatric assessment is probably too complex for non-geriatricians, for folks who work in primary care clinics who aren't set up to do comprehensive geriatric assessment because it requires time and a multidisciplinary team, although there are multiple settings in which CGA has proven beneficial. The use of the clinical frailty scale and an assessment of ADLs might be a more practical approach. And we'll see on the next slide the clinical frailty scale, which is divided into essentially three groups: the preserved function group, the loss of function but preserved autonomy for most ADLs, and the severe loss of function and autonomy for almost or all ADLs. So this is the clinical frailty scale. So you see the little silhouette cartoons, and from 1 to 3, we have very fit folks, we have well folks, we have folks with some medical problems that are pretty well controlled, but not regularly active, but managing well. And then in the middle group, sort of scales 4 and 5, we have some vulnerable listed as 4, not dependent on others for daily help, but their symptoms limit some of their activities. Those who are mildly frail, these folks have more evidence slowing. They may need help in their higher order IADLs, but they need some help with some of their ADLs as listed. And then in the last group, we have folks that range from moderately frail to terminally ill, those who are approaching the end of life, who might be eligible for hospice, and in between those, folks who are actually quite frail as well. This is actually a scale that's used by our trauma surgeons and our trauma surgery service, excuse me, to help guide geriatric, a geriatric bundle, including geriatric medicine, consultation, and other specific interventions to try to reduce complications. So here's a case. We have an 83-year-old man. He has diet-controlled diabetes and hypertension without complications of either. He evidently has hypertension twice. He also has some osteoarthritis. He presents for a physical. He hasn't been seen in person in 2 years. He lives independently in an apartment, but he's active. He walks 30 minutes 3 to 4 times a week, despite living in Seattle. On exam, he's mildly overweight, but he walks without assistive devices. He appears steady. He's able to arise from a chair without using his arms to lift himself. His heart rate's 86, blood pressure 162/70, which is higher than the last time he was in clinic, and his exam is otherwise unremarkable. So he's a fella that would fit in group 1. He's doing really well. He lives independently. He's not dependent for any of his ADLs. He exercises regularly. So he's somebody that you would consider, and this is just a reminder of what the ADLs are. He's somebody that you would consider using the normal blood pressure levels to call hypertensive and normal or standard rather goals for the treatment of hypertension. Then we have a patient who's 88. She has mild to moderate dementia. She has a history of AFib and mild coronary disease, but no angina. She's had a couple falls in the last 2 years, which she attributes to tripping on some throw rugs, which have since been removed, and she hasn't fallen since then. She does use a walker. She lives with her daughter and son-in-law. They help her with a couple of ADLs, preparing food and bathing to make sure she's safe in the bathroom. So in this group, in the middle group, this is the loss of function but preserved most ADL profile. Folks usually have 1 or 2 comorbidities. They may have moderate cognitive and functional decline. These are folks where you might consider tailoring therapy and potentially deprescribing. It's been estimated that about 25 to 40% of the group 4 patients and the vast majority of group 5 on the clinical frailty scale would have been excluded from HIVET. So that's an awful lot of people. Further categorizing folks in this middle group may require comprehensive geriatric assessment to see if they have one of the geriatric syndromes to better suss out their degree of functional impairment and need for assistance. So in this middle group, if there are few comorbidities and minor loss of autonomy, you might consider treating those as the preserved function group, so like other adults. On the other hand, if they, after your assessment, you conclude they really have multiple comorbidities, geriatric syndromes, and are dependent for multiple ADLs, you might decide to treat them as members of the next group, the loss of function and altered ADL profile. And that's exemplified from by this gentleman. He's 96, he has metastatic prostate cancer. He is hypertensive. He lives in an adult family home. He's wheelchair bound. He needs assistance for all of his transfers, in addition for toileting, dressing, although he eats without assistance. He is mentally quite active. He does the crossword every day, but he is dependent for all of those ADLs. So this is somebody that falls into the loss of function and altered ADL profile, has at least one of the following: multiple comorbidities, severe dementia, significant geriatric syndromes, dependence. Most of these folks are over 85. In these folks, your treatment really should be tailored, emphasizing symptom relief and quality of life. It's particularly important to be talking about shared decision-making in this age group, or in this group, and having a multidisciplinary approach. So having everybody who's involved, whether that's the patient's cardiologist, neurologist, PCP, pharmacists, caregivers, knowing what their goals, their common goals are. You might consider, to avoid acute complications, keeping the blood pressure under 150, but dose reducing if the blood pressure falls between or falls to below 130, or if there are signs and proven orthostatic hypotension. You want to monitor for and manage malnutrition, dehydration, the influence of other medications, particularly those that might exacerbate or cause orthostatic hypotension, and consider deprescribing as with other conditions. So this is from the Benito's article showing how to approach the preserved function group, the loss of function but preserved ADLs, where you might have a group that you consider doing pretty well and treating as preserved function, versus those who are actually significantly altered and significantly have significant functional decline and might treat them as a loss of function and altered ADLs kind of age group, considering deprescribing, being much more liberal with hypertension goals. As with every hypertension talk, I have to talk about lifestyle modification, which has been all of the interventions on the left, or all of the modifications, have been associated with improvement in systolic blood pressure. Those are just some ranges. Not all of these are going to be appropriate for older adults, particularly frail older adults, or those who have mobility problems. They may not really be able to be physically active, and it could in fact be somewhat dangerous, or the type of physical activity may need to be changed. If there's supervised pool exercise, that would probably be preferable, even though it's not weight bearing if you're in the water. Sodium reduction may in fact result in volume depletion, orthostatic hypotension. Weight reduction may actually not be advisable for some older adults who are having trouble maintaining their muscle mass, and sarcopenia, or loss of muscle mass, is one of the cardinal markers of frailty. So even though these may be effective, some of them may be potentially detrimental. In terms of pharmacologic treatment, the guidelines, there are some particularly favorable or recommended uses, and that's when there's some comorbidity that might be simultaneously treated. So ACEs and ARBs in folks with mild renal impairment, or beta blockers in folks with heart failure or atrial tachyarrhythmias, for example. You want to be cautious with high doses and combination therapy, because we know that the ability to take medications as prescribed falls with the more medications there are, and there's always the potential for side effects and interactions with other medications. Common side effects from almost all classes of blood pressure medications can include fatigue, delirium, orthostatic hypotension. Immediate release or very short-acting medications tend to increase the risk of orthostatic hypotension, the kind of ups and downs that we in general want to avoid. Centrally acting medications may have CNS side effects, particularly in older adults. Others can cause urinary incontinence. And then there are the traditional complications like hyperkalemia that can result in or from renin-angiotensin-aldosterone medications. This is a slide that you may refer to subsequently, but just a few things to note. Calcium channel blockers can cause lower extremity edema and can complicate the diagnosis or evaluation for heart failure. Constipation with verapamil is not rare. Beta blockers, as in younger folks, can cause fatigue and can result in some degree of or concern for depression or depressive symptoms. Conduction system disease can be exacerbated by beta blockers, and acetylcholinesterase inhibitors, which are used sometimes used in Alzheimer's disease, together with beta blockers and other AV nodal blocking agents, may result in bradycardia. So just a few points on meds. So here's another case. We have an 82-year-old man, hypertension, BPH. He comes to clinic complaining of intermittent lightheadedness and unsteadiness that began last week. He was visiting family in Arizona, and they were outside a lot. He's on hydrochlorothiazide for his hypertension. He's on prazosin for his BPH. His blood pressure is 120/70, his heart rate 68, and then his standing blood pressure drops to 100/60 with a heart rate of 81, and he did feel lightheaded. So this is sort of a garden variety or fairly slam dunk case of orthostatic hypotension, for which the strict definition is listed there. Orthostatic hypotension is generally categorized as non-neurogenic or neurogenic. So non-neurogenic is sort of the garden variety orthostatic hypotension. It can be caused by reduced cardiac output or from impaired vasoconstriction, but is without a primary autonomic disorder, can be due to medications or volume depletion, or just from aging, which causes arterial stiffness and can impair baroreceptor function, resulting in an inappropriate drop in blood pressure and a lack of an increase in heart rate to counteract that drop in blood pressure, resulting in those postural changes. Interestingly, folks with orthostatic hypotension often have increased blood pressure variability with exercise postprandially and with between check variability. And these are probably due also to impaired or aberrant baroreceptor function. Neurogenic orthostatic hypotension, on the other hand, is secondary to an actual neurogenic etiology or disorder. This is a little bit of a busy slide for those who are into mechanisms. Feel free to read now or later. But it is secondary to some other disorder that can be diagnosed, but is often can be difficult to diagnose. Neurogenic orthostatic hypotension, though, is a debilitating disorder. And it carries significant morbidity and mortality, not unlike regular orthostatic hypotension, which is a risk factors for falls and fractures and other adverse outcomes. Neurogenic orthostatic hypotension, interestingly, and sometimes consternatingly, it's not the right word, but can cause consternation because it can be also complicated by supine hypertension. All types of orthostatic hypotension have these risks. Better hypertension control can actually reduce or improve orthostatic hypotension. So that's often a paradoxic finding that we see. So in the evaluation of orthostatic hypotension, you start with just the diagnosis, seeing the drop in blood pressure, and then, the first thing is just to see, are there meds responsible? So for this gentleman, he's on a mild diuretic and also on prazosin, both of which can cause either volume depletion, particularly when he was in Arizona. Older folks have impaired thirst mechanisms, could have become volume depleted, and then on top of those medications had symptoms. Can you reduce or discontinue the symptoms? And that may be all that's needed. And for the vast majority of folks, that's going to be enough. Some may need non-pharmacologic, and then those that don't respond to non-pharmacologic conservative treatment, they may need medications. Whereas other folks, and then evaluating for volume depletion. Other folks may have signs or symptoms that are concerning for a neurogenic cause of orthostatic hypotension. And so these are folks that have Parkinsonian features, other signs of autonomic failure. They have already diagnosed alcoholic polyneuropathy. They have multiple sclerosis or other diagnosable conditions. And then, up in the upper left, other non-neurogenic causes, congestive heart failure resulting in poor cardiac output, folks with volume depletion, adrenal insufficiency. This is just, again, a list of non-neurogenic and neurogenic etiologies, and then medications that can be problematic. Sometimes folks don't have a choice, but dose reduction may allow for improvement in the symptoms, at least to get them out of the dangerous drop range. Some non-pharmacologic treatments for orthostatic hypotension involve sort of pre-exercise before standing to try to get that skeletal muscle pump to increase venous return. It's somewhere between 300 and 800 cc's are thought to go to the lower extremities upon standing. So trying to mitigate that. Eating smaller, more frequent meals, increasing salt and fluid intake, elevating the head of the bed. And we'll talk a little bit about that when we're talking about supine hypertension. And then here's a list of some things to avoid. So, you'd probably be in a hotel where there's a swimming pool and either a hot tub or a sauna where they, say, be careful if you have any of these conditions. Those are places to avoid if you or your patient has a tendency towards orthostatic hypotension. So pharmacologic therapies, you'd really like to avoid if possible. I have not prescribed NSAIDs, which can result in increased intravascular volume. Also, uncommonly, some folks may need other pharmacologic interventions. Midodrine does have a randomized control trial. It's a vasoconstrictor, but it may have the complication of supine hypertension, as might Florinef, which is an off-label use to expand intravascular volume in folks who tend to, who can't keep their intravascular volume even with salt and fluid intake. And erythropoietin has seen some benefits. So here's a patient, he's 73, he has Parkinson's disease. He's unsteady on his feet. His family is very attentive, but they've noticed that his blood pressure is quite high at night. They first checked when he once had a headache. Sitting, his blood pressure is 127/64. Upon standing, he drops to 100/53. But his supine blood pressures last week ranged from 173/80 to 208/93, and they were pretty concerned about that. So again, about half of patients with neurogenic orthostatic hypotension have supine hypertension. This is the consensus definition. Their blood pressure may be normal, as this gentleman's was, even a little bit on the low side when seated. The majority are so-called no dippers, so their nighttime blood pressures don't dip at night. Although a third of patients with supine hypertension do have a blood pressure decrease after a normal dip. The treatment of supine hypertension has to balance the risks and the benefits. The reason to treat is to lessen the cardiovascular risk, so end organ damage. There's a fear that the treatment will worsen orthostatic hypotension. Some evidence suggests that orthostasis may actually improve. Some interesting features of supine hypertension are that with this increased venous return that accompanies the high blood pressure, this can result in nocturia, which can then disrupt sleep. But folks can lose then about a kilogram to 2 kilograms of water weight while they're asleep. And that in turn can result in orthostatic hypotension during the day, or in the morning rather. So some of the conservative things to treat supine hypertension are to avoid offending agents, so things that might be causing high blood pressure like NSAIDs. Limit fluid ingestion near bedtime to lessen the chance that there's that increase in blood pressure from increase in venous return. Avoiding things like fludrocortisone that might be administered for orthostatic hypotension in the daytime, because that may worsen things in the night. Tilting the bed up is actually a pretty effective measure to stop that venous return. So even if you can tilt the whole bed up by about 10 degrees, that is actually enough to mitigate that increase in venous return and supine hypertension. It has to be the whole bed at 10 degrees though. There's a little bit of data that if you have a hospital bed and you can only tilt the head of the bed, if you tilt that up to 30 degrees, that may also be effective. Angles over 30 degrees, folks tend to just slide back down. So pharmacologically, if you need to treat the supine hypertension, there's a lot of sort of trial and error we'll talk about, and potentially shorter acting agents. You don't want to give them something that's going to lower their blood pressure that's going to have a big carryover effect, which can be hard to estimate because there may be variable clearance in older folks. Ambulatory blood pressure monitors may be useful so that you can get data sort of around the clock to see what their blood pressure trends are. There are some particular considerations which are a little bit beyond the scope here for folks with autonomic failure and multi-system atrophy in terms of medications that may be better to use or avoid. Again, ambulatory blood pressure monitors may be useful for these folks, and particular agents may be beneficial. And then some cautions. Interestingly, in the RAS family, losartan was shown to be more effective than captopril, and also decreased natriuresis at night. You want to be careful with vasodilators, and as with all meds, cautious about possible carryover effects, which means that you're going to have to potentially have some trial and error. It's a 79-year-old woman with hypertension and diabetes. She presents frustrated by her hypertension control. She's on the medications that are listed. And despite these, her blood pressure is 160 to 170 over 65 to 80, with a heart rate that's around 100. So, you think to yourself, what should be evaluated by history and maybe some labs? So this is an example of somebody who might fit the definition of resistant hypertension. And that's hypertension that persists despite 3 adequately dosed antihypertensive medications, at least one of which is a diuretic. So George Bachris is a name some of you may be familiar with. He's a kind of a bigwig in hypertension. From a document that he put together, just his approach to an older adult with resistant hypertension. So basically, it's a way to sort of evaluate for another cause or reversible causes of hypertension, and just really some common sense types of things. So want to see if the patient is adhering to a low salt diet. Sometimes he evaluates that with a 24 urine sodium. RAS agents, their usefulness will be overcome or counteracted by high salt intake. Evaluate sleep quality and quantity, including OSA. Folks with OSA will often have a high resting heart rate. He considers using medications to help sleep, which again, might be done with caution by you folks. There's been an estimated or average of a 1 millimeter mercury drop per hour the CPAP mask is worn. Talk about sleep hygiene, evaluate caffeine intake, evaluate other medications, look for CKD, which might indicate that the patient actually needs a loop diuretic instead of just a thiazide for volume and blood pressure, and therefore blood pressure. Evaluate for primary hyperaldosteronism, particularly in folks who have hypokalemia, because in those folks who have hyperaldosteronism, just spironolactone may be enough to render them normotensive. Assess adherence. So I haven't talked much about that, but memory problems, cost, intolerances, confusion can all have an impact on adhering to the medication regimen. And I think we've all probably had the experience of sort of up titrating medications only to find that the patient actually isn't making those changes. And that's something that we can all do better at assessing. Certain medications we'd like to avoid. Oral clonidine in particular has a high rebound effect. Hydralazine, short acting, hard to remember to take multiple times a day. He likes calcium channel blockers and diuretics, adding RAS agents, beta blockers. He likes in folks with poor sleep because chronic sleep deprivation is a high adrenergic state resulting in that elevated heart rate, and that may be effective. Trying to dose folks, at least half of them at nighttime, to give the body the normal drop in blood pressure in folks particularly who aren't dippers. If you're going to use clonidine, then use the patch. There's less potential for rebound. He likes guanfacine, which I've actually never used. It is also sedating, so might help with sleep initiation. So another case, and then a few comments about another related condition. So here we have a 74-year-old gentleman with a history of coronary disease. He's had an MI with a stent. He has peripheral vascular disease. He had a FEMPOP bypass a number of years ago, and hypertension. And his control has been worsening in the last few months. It used to be well controlled on amlodipine and at 5 and long-acting metoprolol 100. But for the last few months, his blood pressure has been elevated and increasing over that time. So this may be a patient with secondary hypertension. So you should suspect this when there's an acute rise in blood pressure in a patient with previously well-controlled readings. Not so important for our purposes, but an onset before puberty is suspicious for secondary hypertension. And in those under 30 who don't have obvious risk factors for hypertension or family history. Those with very high blood pressure, I believe malignant and accelerated are sort of older terms, but very high blood pressures, or again, folks that don't respond to multiple medications may have secondary hypertension, which is another way to get resistant hypertension. So this is a little bit of a busy slide, but some possible conditions that if we focus on the middle column that can cause secondary hypertension: renal artery stenosis. So this patient has multiple atherosclerotic diseases, peripheral vascular disease, and coronary disease. And so he would be somebody that you'd be concerned might have renal artery stenosis. Primary renal diseases, I mentioned hyperaldosteronism, sleep apnea, aortic coarctation, Cushing syndrome, thyroid disorders, pheochromocytoma. In older adults, renal artery stenosis is going to be more common than any of the others, although, obviously some can affect older adults as well. So you want to be attentive to those possibilities. In this patient, renal artery stenosis was the diagnosis for his acute worsening in his hypertension control. And generally with secondary hypertension, as you might expect, you treat that secondary cause, and the hypertension usually gets better. So this isn't a case, but it's sort of the last thing to talk about is the relationship between hypertension and cognitive function. There have been a number of epidemiologic studies, multiple, that have shown ties between hypertension and long-term cognitive function or dysfunction. In Framingham, they showed that having hypertension 20 years prior was associated with poor cognitive performance in folks with untreated hypertension. In the Honolulu Asian Aging study, in various others epidemiologic studies. Some actually haven't shown a link, And that may be because of the duration of hypertension, testing methods, and population differences. Demonstrating benefit of hypertension control for cognitive function is difficult, and it's likely due to the relatively short study durations that we have and the older age at which those studies are done. It's most likely that midlife hypertension that is poorly controlled is a risk factor for future cognitive impairment. There is some suggestion that it may not be simply the blood pressure, but vascular changes that we talked about, the arterial stiffening that may accrue to folks with longer term hypertension that are additional risk factors for cognitive impairment. We don't really know what the target and duration needed is to provide cognitive benefit or cognitive protection. But we do know that lowering blood pressure in frail older adults, probably when it's too late to have a beneficial benefit on cognitive function, may even be worse for those with cognitive dysfunction. So what do we need? We need controlled trials in those with significant comorbidities, loss of function, impaired ADLs. So randomized controlled trials would be great. In addition to registries, observational studies, longitudinal cohorts, it would be great if we could evaluate a management algorithm like the one suggested in the article that I spent a fair amount of time on to see, is this a beneficial approach as opposed to, quote, usual care, integrating frailty and ADL assessment into decision-making and strategy choice or stratification. Here are some references that I used in putting this talk together. And that's the end of my formal comments, but I'm happy to take questions at this point.
Do we have questions? Oh, here's one. You mentioned your folks being aware of salt intake. I work with active seniors. How do you address post-exercise low blood pressure, like 90/60 with dizziness, but when they go to the doctor for eval, they have high blood pressure due to stress of driving to the doctor, the Fitbit effect?
Yeah, that's really interesting. I don't know if it's older adults in particular, but my dad in particular also has that effect of a lower blood pressure. I think that's a situation in which an ambulatory blood pressure monitor or just looking at the log of blood pressures after correlating them with the in-office to make sure there's agreement and accuracy of the home blood pressure measurements might lead to a liberalization of medications. And also perhaps prehydration prior to exercise, even though, if they're exercising for long enough, they may need to urinate, but prehydration might help that as well.
And can you add salt or Pedialyte to water when walking or exercise? Is this orthostatic hypotension volume depletion? They don't like to drink lots of water because of peeing.
Yeah, I think you could certainly try that. It may be helpful.
And then Heather, you had your hand raised. Let's see if I can unmute you so you can ask your question. There, Heather Alt, did you have a question?
No, I think my son hit that button. Sorry.
Oh, okay.
Does he have a question?
So another question is, and I don't know what these are, but NUUN tablets are also helpful for electrolyte hydration.
Oh, yeah, that's they actually, my son plays ultimate frisbee, and at every tournament they have a bunch of those. They're kind of electrolyte tablets, and some of his teammates just eat them, which is kind of gross to me because they're like chalk. But you can dissolve them in water also. So that's a great suggestion. And
how reliable are home blood pressure machines, or should they take the machine to the doctor to check them out?
Yeah, I think no matter what, it's a good idea to periodically bring them in. They don't have to do it every time, but sort of, we like our patients to bring their medications every time, but maybe the blood pressure monitor a few times a year just to make sure it remains accurate. Some of them are more accurate than others. The arm ones tend to be more accurate than the wrist ones. And some brands are better than others. And then also teaching the appropriate way to take a blood pressure. So seated, both feet on the ground, on the floor, arm at the level of, or the upper arm at the level of the heart, seated, for 10 minutes, not doing anything, not watching the news for sure. And then also, not getting too worked up about any one reading. That's something that some of my patients have a real difficult time with. They'll kind of get into a cycle of, oh, I had a high one, and then they got upset, and so then they kept taking it, and it was like high all night. And so just to say that we're mostly interested in the trend, obviously, unless it's very high in their symptoms.
Any evidence of exercise reducing blood pressure in older adults?
Yeah, I don't, I'm not familiar with particular studies. And again, I would expect that in robust adults, it would probably have an effect similar to in the data that's for younger folks. I'm not aware of specific trials, but they have looked at other activities like Tai Chi, and which is not vigorous exercise by any means, but older adults that do Tai Chi have lower blood pressures through that.
Great. Are there risks to be considered for naturally low blood pressure in, for example, a 70-year-old?
Yeah, I think, without symptoms, if they're orthostatic, then you want to make sure that it's not sort of naturally low because they're volume depleted or have some other condition. But if they're just healthy, have quote unquote good genes, then I wouldn't be concerned about that.
And are Fitbits accurate enough to check your blood pressure?
Oh, I don't know the answer to that. I knew that some can do heart rate. I didn't know that they could do blood pressure.
Vascular dementia is common among African Americans. How do you recommend informing and encouraging compliance and better self-care within the community about this alarming and devastating impact? I don't think the masses get the correlation, Karen says.
Yeah, it is a really tough public health problem. And the data from the AHA in terms of heart and stroke statistics is, it's really sobering. I'm not sure how to best approach the messaging with an individual patient. Hopefully just explaining that, even though you can't feel the changes from high blood pressure, that things are happening with the blood vessels, and that's putting them at increased risk for heart attack, for stroke, and multi-infarct dementia, as you've referenced. I don't know on a public health basis. There have been some attempts to try to educate, but clearly they're not enough.
Is there an intervention for hypertension that you find has not been utilized or discussed enough? That's an interesting question.
Yeah, I would say that in general, as a society, we tend to reach for medications, before we really do much with lifestyle. In Seattle, we get a lot of, oh, well, it's raining. Like, you're telling me to go exercise, but it's raining. So it's, to some extent, folks would rather eat a steak and take an atorvastatin. And that's kind of a societal kind of problem. So, you just try to say, well, even if it's raining, sometimes it's not pouring. And there are some inside places that you can do exercise. Now, with the pandemic, which I kind of promised I wouldn't talk about as much, it limits, gym use, even in folks who live in facilities that have gyms. Sometimes there are restrictions on how many people or whatnot. And obviously, sometimes it might not be safe for folks to be on a treadmill or whatnot. But yeah, I think, before reaching for meds, we really should be trying to say what are appropriate lifestyle interventions, and really give those some degree of try, because there tend to be less side effects from lifestyle interventions than there do from medications.
Is there any connection between migraine and high blood pressure during a flare-up?
Oh, during a migraine flare-up, I don't know the specific answer to that. I would imagine that folks' blood pressure would go up just from the pain, but I'm not aware of specific links.
Okay. As an undergrad long ago, Mary was told that a high systolic blood pressure frequently reflects current anxiety. Is that correct?
It can, for sure. It's not necessarily the case, though. Older folks have isolated systolic hypertension, typically just from those vascular changes. But we all will, if we're frightened or revved up or angry, will often be hypertensive.
If blood pressure is normal in the morning, but high in the evening, say at 160 over 170 millimeters of mercury, what kind of treatment is possible?
So certainly, you can time blood pressure medications according to changes that you might see. You'd certainly like to know if it's going up for particular reasons, whether that's, somebody that's drinking a bunch of coffee in the afternoon or whatnot. Smoking also increases tobacco or nicotine. But you can, if you have, pretty reliable blood pressure record, either from an ABPM or home blood pressure monitor and record. Some of the home blood pressure monitors, keep track of the blood pressure, so they can do a printout and show you the time that the person took them and so forth. You may be able to time their antihypertensives. So if you're, I have patients that I have a higher dose of, say, lisinopril in the morning or in the evening than I do at the converse time.
Okay, great. Well, let's see. I do have one more question here, I think. Let's see. Can exercise cause orthostatic hypotension, or is that completely separate?
Generally separate, although, if you're exercising enough to become volume depleted, or some people's blood pressure does go down. So it can be a component or an example of a situation in which orthostatic hypotension happens, whether it's because of something that's reversible or just because folks with orthostatic hypotension tend to have variable responses to things like eating or exercise or changes in position from lying to standing because of the impaired baroreceptor response. It could be from the same mechanism. What to do about it might indicate a need to be seated soon after finishing as opposed to standing. Might involve making sure you're pre-hydrated or timing blood pressure medications. But it may be from similar pathophysiology from impaired baroreceptor function.
helpful. And thanks, Jen, for the reminder. I did just post the link for the evaluation form. And I don't see any other questions, other than there's been quite a lot of information in the chat about how incredibly helpful and accessible your presentation was. The case studies were much appreciated.
Oh, that's
So,
nice.
thanks everyone for coming this week. We will see you next week, and have a great time until then.
Thanks, folks. Take care.
Thanks, Michael.
Nice to see you. Thank you.
Good to see you too.